Welcome to another video from My Hematology, where we make hematology simple. Today, we will be exploring the topic of Hodgkin lymphoma. Before we dive into Hodgkin lymphoma, let's learn what is lymphoma. Lymphomas are a group of diseases caused by malignant lymphocytes that accumulate in lymph nodes, leading to lymphadenopathy. The lymphatic system is a network of vessels and nodes throughout the body that helps to fight infection, and lymphadenopathy is a term used for swelling of your lymph nodes. The major subdivisions of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. So what is Hodgkin lymphoma? Hodgkin lymphoma is distinguished from non-Hodgkin lymphoma by two main features. The first is the presence of Reed-Sternberg cells, and the second is a strong tendency for the Hodgkin lymphoma to arise within a single lymph node group and spread from one lymph node group to the next. So what are Reed-Sternberg cells? The Reed-Sternberg cells are these large owl-like eyes, which are actually large abnormal white blood cells that are found in the lymph nodes of people with Hodgkin lymphoma. They are the hallmark of this type of cancer. Reed-Sternberg cells are thought to be derived from B cells, a type of white blood cell that produces antibodies. These B cells has a crippled immunoglobulin gene caused by the acquisition of mutations that prevent the synthesis of full-length immunoglobulin. They have lost many of the characteristics of B cells and have become cancerous. They may also contain eosinophilic inclusion bodies, which are structures that stain pink with eosin, a type of dye used in histology. Reed-Sternberg cells can produce a variety of cytokines, which are proteins that communicate with each other. And these cytokines can actually help to promote the growth and survival of Reed-Sternberg cells and can also suppress the immune system. The World Health Organization divides Hodgkin lymphoma into two main subtypes. They are the classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Classical Hodgkin lymphoma is the more common subtype, accounting for about 90% of the cases. So classical Hodgkin lymphoma has four subtypes. One, the nodular sclerosis, which is the most common form of Hodgkin lymphoma in young adults. It is characterized by two pathologic findings: the presence of lacuna cells, which are a variant of Reed-Sternberg cells. Their ample cytoplasm tends to retract during formalin fixation so that they are surrounded by empty space in the stain, and the presence of large bands of collagen that are deposited by reactive fibroblasts. This subtype is actually rarely associated with EBV. Secondly, mixed cellularity Hodgkin lymphoma. This subtype is most common in older males, where the lymph nodes are composed of a mixture of inflammatory cells and numerous Reed-Sternberg cells with intermediate number of lymphocytes. About 70% of cases are associated with EBV. Lymphocyte-rich Hodgkin lymphoma. This is not a common subtype with predominantly small lymphocytes. About 40% of cases are associated with EBV. And lastly, we have lymphocyte depleted subtype. This is a rare subtype except in HIV positive patients. There is a dominance of Reed-Sternberg cells with a sparse number of lymphocytes. It is almost always associated with EBV. Next, we have the nodular lymphocyte predominant Hodgkin lymphoma, which is characterized by the presence of lymphocyte predominant cells, sometimes termed as the popcorn cells, which are a variant of Reed-Sternberg cells. It is not common and found primarily in young to middle-aged males within the axillary or cervical lymph nodes. Classic Ritzenberg cells are rare or absent, and it is important to know the subtypes since it plays a large part in determining the treatment the patient will receive. What are the common clinical signs and symptoms of Hodgkin lymphoma? The most common clinical sign of Hodgkin lymphoma is a painless asymmetrical enlargement of the lymph nodes in the neck, underarms, or groin. And the most common lymph node involvement is the cervical lymph nodes, followed by the axillary nodes, and then the inguinal nodes. The lymph nodes may be firm, discrete, and rubbery to touch. Clinical splenomegaly occurs during the course of the disease in 50% of the patients and is seldom massive. Then we have fever, pruritus or itching, alcohol-induced pain in the areas where the disease is present, and hypermetabolism symptoms like weight loss, night sweating, anorexia, or cachexia. Less common clinical signs of Hodgkin lymphoma may include bone pain, headaches, skin rash, jaundice, or peripheral neuropathy like numbness and tingling in the hands and feet. So how do we diagnose Hodgkin lymphoma? Laboratory investigations will reveal pneumochromic pneumocytic anemia and some patients having neutrophilia in the complete blood count. Eosinophilia is also frequent. Advanced disease is associated with lymphopenia and loss of cell-mediated immunity. Diagnosis is made by histological examination of an excised lymph node or fine needle aspirate with the presence of Ritzenberg cell or the variants of it. In specific tests, the ESR and CRP are usually raised, but increase of serum LDH is seen in 30 to 40% of the cases. Ritzenberg cells stain CD30 and CD15 positive in immunostains, but CD45 negative and for other B cell markers too. In contrast, nodular lymphocyte predominant Hodgkin lymphoma are uniformly positive for B cells markers such as CD20, but CD15, CD30, and EBV negative. Once a diagnosis of Hodgkin lymphoma is confirmed, the doctor will need to determine the stage of the disease. The stage of Hodgkin lymphoma is determined by the location of the cancer and the presence of certain clinical signs. The stage of Hodgkin lymphoma is important for determining the prognosis for patients with Hodgkin lymphoma and for guiding treatment decisions. Staging is performed by thorough clinical examination together with chest X-ray and CT scan to detect intrathoracic, intra-abdominal, or pelvic disease. MRI scanning may be needed for particular sites, while PET scan may be useful for staging and when combined with CT scan may detect small foci of residual disease following treatment. The Ann Arbor staging system is the most commonly used staging system for Hodgkin lymphoma. The Ann Arbor staging system is based on the location of the cancer and the presence of certain clinical signs. Stage 1, the cancer is limited to a single lymph node region or to a single organ outside of the lymphatic system. In stage 2, the cancer is limited to 2 or more lymph node regions on the same side of the diaphragm or to a single organ outside of the lymphatic system and to adjacent lymph node regions. Stage 3, the cancer is located in the lymph node regions of both sides of the diaphragm or is located in the spleen or bone marrow. And finally, for stage 4, the cancer has disseminated to multiple organs outside of the lymphatic system. For example, it refers to diffuse or disseminated disease in the bone marrow, liver, and other extranodal sites. In addition to the stage numbers, the letters A, B, E, or X may be used to further classify the stage of Hodgkin lymphoma. Category A means that the patient does not have the B symptoms, which are hypermetabolism symptoms like unexplained fever above 38 degrees Celsius, night sweats, or weight loss. Category B means that the patients have B symptoms. In category E, the patients have Hodgkin lymphoma cells in the organs or tissues outside of the lymphatic system. And category X is indication of a bulky disease, which means a lymphoma that is greater than 10 centimeters or 4 inches wide. For example, a patient with Hodgkin lymphoma that is localized to a single lymph node region in the neck and who does not have B symptoms would be classified as Stage 1, Category A. The Ann Arbor staging system is a useful tool for determining the prognosis for patients with Hodgkin lymphoma and for guiding treatment decisions. Hodgkin lymphoma patients with early stage Hodgkin lymphoma stage 1 or 2 generally have a good prognosis and can be cured with radiation therapy or chemotherapy. And patients with advanced stage Hodgkin lymphoma, which means stage 3 or 4, have a worse prognosis, but many of these patients can still be cured with a more aggressive treatment regimen. What is the current treatment for Hodgkin lymphoma? The treatment of Hodgkin lymphoma depends on the stage of the disease and the patient's age and health. The main goal of the treatment is to achieve remission, which is a state in which there is no longer any evidence of the disease. Treatment is done with radiotherapy, chemotherapy, or combination of both. Radiation therapy is a type of treatment that uses high energy rays to kill cancer cells. Radiation therapy is often used to treat early stage Hodgkin lymphoma, which means stage 1 or 2. Radiation therapy is typically given in short daily sessions over several weeks. Chemotherapy, on the other hand, is a type of treatment that uses drugs to kill cancer cells. Chemotherapy is typically given in cycles, with each cycle lasting several weeks. Cyclical chemotherapy is used for stage 3 or 4 disease and also in stage 1 and 2 patients who have bulky disease, type B symptoms, or have relapsed following initial radiotherapy. The combination of adriamycin, bleomycin, vinblastine, and dacarbazine or ABVD is now most widely used. Stem cell transplantation is a procedure in which healthy stem cells are transplanted into the patient's body. Stem cells are the immature cells that develop into different types of blood cells. Stem cell transplantation can be used to treat patients with Hodgkin lymphoma who have relapsed after initial treatment or who have not responded to initial treatment. Before we wrap up, let's go over the key points of Hodgkin lymphoma again. The common signs and symptoms of Hodgkin lymphoma include painless asymmetrical lymphadenopathy, splenomegaly in 50% of the patients, and constitutional symptoms, for example, hypermetabolism symptoms like fever, weight loss, and anorexia. There are two main subtypes of Hodgkin lymphoma, which are the classical Hodgkin lymphoma, including the nodular sclerosis, mixed cellularity lymphocyte rich, and lymphocyte depleted Hodgkin lymphoma. And then we have the nodular lymphocyte predominant Hodgkin lymphoma. Laboratory investigations related to Hodgkin lymphoma include pneumochromic pneumocytic anemia in the full blood count, increased ESR, CRP, and LDH, presence of red Sternberg cells on the lymph node biopsy, and EBV positive in certain patients. Tumor cells are CD15 positive, CD30 positive, and CD45 negative for classical Hodgkin lymphoma. And in nodular lymphocyte predominant Hodgkin lymphoma, they are CD20 positive, but CD15, CD30, and EBV negative. The treatment and management of Hodgkin lymphoma includes radiotherapy, chemotherapy, and stem cell transplantation for patients who have not responded to the initial treatment. If you like this video, click like and subscribe for more videos, and thanks for watching.